Field, and I'm the principal investigator for Wisconsin Voices for Recovery, and really happy to be here today. And welcome. And today we have the privilege to be joined by Dr. Nicole Gastala. Dr. Gastala is the Director of Behavioral Health and Addiction at the University of Illinois Health Miles Square Health Centers, which is an academic, federally qualified healthcare system within the University of Illinois Health System. Dr. Gastala is also an assistant professor of clinical family medicine in the Department of Family Medicine at the University of Illinois, Chicago. She is board certified in both family medicine and addiction medicine, and she provides a full spectrum of outpatient family medical care, as well as medications for opioid use disorder in a variety of settings, including working with underserved populations. So welcome, Dr. Gastala, and thank you so much for joining us today. And I know you have worked to care for people with opioid use disorder, as I mentioned, in a variety of settings. And could you please talk a little bit about your very first experiences with medication-assisted therapy? Like especially, I know that you were working in a rural area. So could you tell us a little bit about that experience?
Sure. Thank you, everyone, and thanks for having me today. So I was trained as a family medicine physician. I graduated from the University of Iowa residency program, and I was in the National Health Service Corps, which means that once you graduate, you go to an area of underserved, and it can be rural or urban. So I went to a town called Marshalltown. It's in rural Iowa, kind of in the middle of the state. And when I got there, I was very interested in sort of preventative health. I hadn't actually had much addiction training during my residency, but when I went to the town, I started to see a lot of patients who had substance use disorders, particularly opioid use disorders, and it was really hard, of course, for them to engage in their other preventative care because the reality was there was no treatment center within an hour radius. And so we were lucky enough in town to have the substance abuse treatment center of that region of the state. So I went to them and sort of asked, like, okay, we're getting a lot of these patients. Like, what do you think? What are your recommendations? And at that time, they only provided therapy services. So sort of the level 1, 2, and 3 of ASAM. But no medications, right? Because it was mainly therapists and peers. And the director had said to me, well, have you heard of M.A.T? Have you heard of medications for opioid use disorder? And I said, well, no. And then she's like, oh, and then she explained to me, and then I joined an ECHO, which is a model of training for rural clinicians, where sort of a hub center will educate a group of like clinicians across the state or across the country, however it may be. And there's a certain number of individuals that join, and there's didactics and case discussions. And that's sort of how I got introduced to buprenorphine. And then we applied for a opioid expansion grant through HRSA. I got my waiver and then started treating myself and the other doc in the clinic. And that's sort of how we got started. So not part of my training initially, but I think part of the reason why we go into family medicine and why we join the service corps is because we really want to meet the needs of our community. And that was a big unmet need within our community. And of course, I was a little nervous at first because I hadn't had that sort of formal training that you like get comfortable with like from residency. But within the first few patients, it really, I really found it to be like probably one of the most satisfying aspects of my job that I've ever had. Like being able to be there for people when they're ready to sort of make a change and help support them through that process when a lot of times the healthcare system hasn't been kind to them, and really work with them to really meet them where they're at, help them meet their life goals and healthcare goals. And so I felt really lucky and very privileged to be able to do that. And it has really helped in terms of like me really enjoying my job. So I found like addiction treatment and working with my patients to be very, very like satisfying and a really great experience. And so I started to integrate it more and more as part of my practice. We helped other FQHCs in the state sort of set up similar programs. And then my husband and I grew up in Chicago. So then when he graduated from fellowship, we looked for positions back in Chicago where our family's at. And I was lucky enough to find a position at Mosque Square Health Centers, which is a FQHC system. So again, underserved setting, and given the opportunity to develop their behavioral health and addiction program and integrating that as primary care, because one of the nice things about going to a primary care office to get treatment is that no one knows why you're there. There's anonymity, right? Like you're just there to see a doctor and like their staff, and it can be, I think, a really healing experience. And so I've been really privileged to be able to help build our program here now.
That's amazing. That's amazing work to have started a M.A.T program within, within a rural area as a brand new program and incorporated into your practice. So thank you for that. And as we talked about too, in your current position in Chicago, you also work with diverse populations. And could you tell us a little bit about like some of the differences? You mentioned the work at your clinic, but also I know that you have been involved with mobile health care for underserved populations. Could you tell us a little bit about that and your work in the Chicago area?
Sure. So I think one of the biggest differences between Chicago and other areas of the country, especially rural and suburban, is that the opioid epidemic here is pretty old. It's been here for decades. So there's sort of two patient populations. So there's a younger Latinx and white or Caucasian population, but then there's also a lot of the patients I treat are actually 50s and 60s African American men and women. And they have been using for 10 or 20 years, and they didn't get addicted, through the healthcare system. It was sort of a different sort of avenue that they had been exposed to opioids and heroin. And so that is a little bit sort of a different, and it has a lot to do with the inequities that's in Chicago, especially racial inequity here. And so in terms of, so that's sort of our patient population that we see here. For the mobile, one of the kind of amazing, like I would say, silver linings from COVID, if there is any, I know people say like what, but there are a couple. And one is the fact that the DEA and SAMHSA and most states have relaxed their guidelines regarding treatment of opioid use disorder with Suboxone or buprenorphine via telehealth. Before there was a federal rule that you had to see a patient in person, and you couldn't do it via telehealth, which of course is really hard for patients in rural areas who have limited access, as well as patients with significant social determinant of health challenges, right? Those who are unsheltered homeless, have difficulties with transportation, and not easy access to clinics or their work schedules, whatever it may be. And so we worked with a group called Night Ministry, and they do street outreach to the south and west sides of the Chicago, so our catchment area in terms of patients. And they provide services via van or a mobile van or bus to homeless encampments. And they provide harm reduction, so naloxone, clean needle exchange. But there was several individuals who were asking for access to treatment. And during COVID, a lot of places had shut down or sort of stopped taking new patients. And so this was an opportunity, one, to start using telehealth because now it's allowed, meeting patients like physically where they're at, whether that's on Lower Wacker Drive or under a viaduct, wherever it may be, to really engage them when they're ready and they're asking for help, and not making them jump through all these hoops to come to clinic the next week or the following day or travel all the way down. We could literally see them do an assessment, confirm they have opioid use disorder, and then send a prescription to whatever pharmacy is closest to them, and then they could start and do a home induction that day. So really taking away all of those barriers for our most vulnerable patient population. So that's sort of what we focused on. And it's been, I think, really successful in the sense of being able to create that link to healthcare for patients who really struggle with access.
Oh, that's great. That's great. And that kind of leads into the next question, which is a little more general too, because and I liked how you addressed the sort of silver lining to the COVID pandemic, if there is one. But we know that I know here in Wisconsin, and I'm sure in your area as well, we have seen an increase in opioid overdoses since the pandemic. And so for your patients that are in recovery, like what has changed for them during the pandemic? And then, specifically, and I know we do have telehealth, but are there other things that patients can do to stay, connected with their healthcare team or just feel less isolated in general? Because that's what we hear, the main concerns are why they, are relapsing or just, having a lot of feelings of anxiety and a lot of other issues is the isolation. So what are you recommending for your patients, and how is the situation in your area?
Sure. So the situation in the area is we are in the city of Chicago not doing very well. The overdose rates this time of year compared to last year are double. So it's a really big concern. And I think if you didn't have depression and anxiety before the pandemic, you definitely have some touches of that now. Like we haven't seen anything like this in a century, right? So add on, if you have already underlying mental health or substance use disorders, or disabilities or anything else that makes this more challenging, it's very normal to sort of feel that way. So I think the first step is really recognizing and normalizing that it's okay not to feel okay. And the best thing to do is to really reach out for help. So those, and whatever that may be, maybe that's frequent calls with your health team, maybe it's frequent calls with your sponsor, or if you have a peer recovery coach as part of the system, joining some of those online Zoom or meetings is really great. But even if you can join via phone, if you're having difficulties with access in terms of the digital divide, like you don't have a phone or a tablet or any sort of or internet, this is when I would sort of reach out to your local healthcare system or local advocates to see if there is a way that you can get lent or donated or given a device in order to help you link to care. I think you don't know if you don't ask. And so I definitely think that there's a lot of support and interest in supporting patients during this time. So the first step is really just reaching out and saying like, hey, I need some help, and know who your network of support is. Also trying to find work on and incorporating mindfulness as well as other sort of positive ways in terms of reinforcing like how you're feeling, and then also harm reduction, right? Making sure if you are going to use, let someone know, leave the door open. There's a great sort of safety suggestions that have been developed, I think, by the CDC, and in terms of those who continue to use. And so just trying to do that in a safe manner, make sure you have naloxone in the house, and whoever lives with you is trained to use it.
Right. That's great. Thank you. Thank you. So then, I know we talked a little bit about telehealth already, so maybe I'll skip over that a little bit, because I also want to ask about, medication-assisted treatment in particular. And so I guess, like you said, when you first were in, family medicine, you might not know all of the, options. And I guess if you could speak a little bit about what are some of the advances in M.A.T and then behavioral therapies that have made a difference. And then maybe the second part too is, we also see there's still so much stigma about, medication-assisted therapy in general, and what can we do as voices as an advocacy organization or just as citizens to help overcome that, and really speak with patients about the benefit that it can have and that it can help them on their road to recovery.
Sure. So when we look at the science and evidence behind medications for opioid use disorder, we know that buprenorphine and methadone, both of them decrease morbidity and mortality independent of counseling. And so that's really important, I think, to understand as well as to share with patients. In terms of efficacy between either of those options, they're depending on which study, it's anywhere between 50 and 80%. And so really the type of medication is really patient dependent. So I think it's really important to discuss all three FDA approved options with the patient. So either buprenorphine, methadone, or naltrexone, discuss what the, how you take it, where you have to go, because methadone, you have to go in person for the first 90 days, 5 days a week. Buprenorphine, you can get weekly prescriptions, and you can, go to your primary care doc. Naltrexone, you have to be off any opioids for 7 to 10 days. So there's some, variations in terms of which one. So you have to really decide which one is going to work for you and which one is going to work for your lifestyle, because the medication that's going to work the best is the one that you're going to take, right? So that's sort of the very first thing. In terms of the stigma around medications, a lot of times people will say, like out in the community or sort of like old school, not evidence-based, is that you're just replacing one addiction for another or one medicine for another. But the reality is when we use the DSM-5 criteria, which is the criteria used to diagnose opioid use disorder, there are several different questions we ask. And in order to get the diagnosis, you can't just be dependent and you can't just have withdrawal when you stop. It has to be the behaviors around it. So if you are taking a medicine and you're not taking it to get high and it's helping you stabilize, you're engaging in your family and work, helping meet those sort of social, educational, and economic goals you have, then it's not replacing one addiction for the other, because you're not meeting criteria anymore. You're not hitting any of those other behaviors around it. And just like any other medication, like a patient who is taking insulin, right, for diabetes, we don't say that they physically must take insulin, right? Otherwise their blood sugars get really, really high. And so although they're physically dependent on insulin, they're not addicted to it, right? Just the same thing, patients who are on methadone or on Suboxone are not addicted to the medicine, they're dependent and tolerant, but it's helping them stabilize. And so the only reason you would ever take someone off of one of those medicines is if there was a contraindication or they weren't benefiting from it anymore, or they were having side effects from it, right? Just like you would for any other medication that you're using to control a chronic disease. If I'm giving someone insulin, as long as it's working for them, why would I ever take them off of it? So I think it's really important that we, as a group of like advocates for this, and for our patients, that we understand the science behind it. We go based off the evidence, not based off of, hearsay or sort of the old mottos from the past, who were really honestly discriminatory and not evidence-based and stigmatizing, and really looking at people with addiction as having a moral failing rather than having a chronic disease, which we know that is what it is. Just like diabetes, just like hypertension, just like asthma. And so it's really important to take away that labeling, being cautious of the words that we use, and also making sure that we arm our patients with the knowledge, and our colleagues, front desk staff, anyone we encounter, to really educate them about what the evidence shows is the best treatment for opioid use disorder.
Oh, that's great. Thank you for that. That's really an important message. Yeah. So I know we want to leave a little bit of time at the end for questions, but I do want to ask you, because we always like to, ask, if someone who's listening today is, if they're struggling with substance abuse, what would you tell them? What would be the message to that's important for them to hear at this time?
Yeah, I think that's a really great question and really important in this time. So I would say, please reach out. There are people who want to help you. We are going to help you meet your goals, whatever that may be, whether it's to decrease use or cessation, it doesn't matter. We're here to help you meet your goals and to continue life in the most safe way possible, and really help you live your best life, whatever, again, that may be based off of your own goals. So please reach out to your local clinicians, to this team, and really sort of arm yourself with the knowledge and get a good group behind you, and we're open to helping.
Oh, that's great. Thank you. So I don't know, Monte or Jesse, were there any questions in the chat, or does anyone on the line have a question for Dr. Gastala?
No, there aren't any questions at the moment, but I did want to say I really, really appreciate your words. Very candid about how you speak about it, and it's true that that stigma is something that we're really trying to tear down. So thank you for saying that.
Yeah, it's really important. I feel like all of us have a role in doing that, right? Arming our patients with that knowledge, talking to anyone we know when we hear sort of disparaging words, and not in a condescending way, addressing it, but in just more of an educational way, that about how we should be referring to patients who have substance use disorders. It's really important that they're not being labeled, and that they are treated with respect and dignity, just like any other patient we have. It's very important.
Thank you. Any other questions from folks on the line?
I just had a comment, and then I do have a question for you as well. But I absolutely love that perception that you have regarding M.A.T and the stigmatization that comes along with it. I think one of our main focuses and goals, our mission at Wisconsin Voices, is to create a space where people who are on M.A.T are not stigmatized. And so I absolutely love everything you had to say about that. I think it should be a PSA that we should just broadcast. And I feel that, people who are on M.A.T not only are stigmatized by, maybe it's the general public or, physicians or police officers. I mean, there is so much stigma regarding M.A.T with people who maybe aren't as educated as yourself regarding it, but there's also stigma inside the recovery community itself. There are people who maybe struggle with alcoholism who view someone that struggles with an opioid addiction that's on M.A.T that gets this terrible thing. And that's something that we hear and see all the time. And hearing you say it from a physician's perspective is just so heartwarming, because you get it, and we try so hard to continue to break down those walls of stigma. Like, it doesn't matter what your addiction is, and one not judge how we get to that pathway to recovery. So I thank you for that. My question for you is, something I think we're struggling with in Wisconsin is, and I don't know if it needs to be a regulation or a law, but when physicians prescribe opioids or like buprenorphine, naloxone, Narcan's not given with it, like automatic, right? And I don't know why. So if I go in and I'm asking for Suboxone or Subutex or any type of buprenorphine medication, or even if I want to get on the Vivitrol shot, why isn't Narcan given to me right away? Why is that script not in my hand with it?
Yeah, I think it has to do with sort of quality improvement and process improvement. So we're working at our hospital system for any time you're prescribed an opioid, buprenorphine, or being treated for opioid use disorder, that's automatically sent to the pharmacy. I think it has to do with education of clinicians, as well as, I don't know if Wisconsin, we have a standing order in the state of Illinois for people who can just walk up and get naloxone. But the problem is it depends on your insurance, whether it's covered or not. Not all pharmacists know about it. So there's even challenges here regarding access to that. So I think it's really important that we need to start training clinicians and pharmacists that whenever you see an opioid prescribed, or Suboxone or naltrexone or methadone, that is automatically put in there as well. And so part of it could be an IT thing that we could use to improve. Part of it is education and training, and then also trying to automate things as much as possible, which would be like really important. So that is, I think, a really great area that needs to be improved, as well as education campaigns for lay individuals in the community to learn as well as the family members and friends of those, because that can be really impactful too. And I kind of want to get back to what you said about like the stigma within the recovery society. I've seen that quite a bit, like especially like if it like went through sort of the old sort of where like I was stronger than you. I did it without any medicine. You hear and see things like that, or like within Chicago, if you use IV rather than snort heroin, the snorters feel like those who use IV have it more severe than them and it's worse than them. So you do hear about that as well, which I think is really like sad, and something that we also need to address, because that's unfair, because you're supposed to feel safe within that recovery community, not judged, right? You're judged by everyone else. You're judged by your family. You're judged by the healthcare system. The recovery space is supposed to be sort of a safe system. So part of that you can also use the example with diabetes. If you have a patient who, completely does like a lifestyle change and they only had mild and they didn't necessarily need medication, do you think they go and talk disparagingly about the patients who are diabetics who need insulin? No, that doesn't happen, right? Like we don't do that within other disease processes. So why do we do it like within this one? Again, it gets back to people looking at it as a moral failing, which is inaccurate and not evidence-based. So I think part of it is educating. This is a chronic disease. You have a chronic disease, they have a chronic disease. There's not one that's worse than the other, in the sense that there's something wrong with them because they use IV heroin when I only drink alcohol, right?
Right. That's so important. Thank you so much for your perspectives. I see that we're at the end of our time. So unless there's any other burning questions, we'll sign off. But I do want to say thank you so much, Dr. Gastala. We really, truly appreciate your insights, and thank you for the work that you're doing and the compassion that you bring to your practice. We really appreciate it. Thank you.
For having me. Continue the great work and reach out if you need anything.
Great. Thank you. Thank you. Take care, everyone.
Bye.
Thank you. Bye-bye.